think that's perfect.
Okay. Can everybody hear me okay still?
Excellent.
Yep.
Perfect. Okay. So I am doing limb reconstructions with amputation planning and level of those amputations. All right. So I tried to keep it pretty simple. I know in the past with a lot of these other presentations, we've kind of gone into everything as far as how to prevent the amputation, who's at risk, and all that kind of stuff. I just kind of touched lightly on this before we get into the level of amputations and that kind of stuff. But as we know, in our population, the people that are at risk mostly are those diabetic patients, especially those with neuropathy, peripheral vascular disease, in some of the more rural areas, those with poor functional status and as well as end-stage kidney disease, particularly dialysis patients. Patients that do have peripheral vascular disease and diabetes are more on almost like a tenfold increased risk to end up with some type of amputation. And pending what that vascular status is, that can determine what that level of amputation or how much amputation that they have. All right. So when do we need to amputate? Particularly in our case, it's a lot of times in those patients that we see osteomyelitis with or infection in the bone or some form of significant vascular disease with ischemia and gangrene, whether that's dry or wet. That's really going to determine what level we need to amputate at. There's also those cases where we have chronic non-healing wounds and things like that, and a patient can ultimately decide if they want to perform some type of amputation to try to get this wound to heal or get rid of the wound and get back on with their life. So that's really why we're going to amputate or perform that amputation. This was a neat picture that I found, and I thought it kind of really directs when we need to amputate, and kind of the three most common things that we see for amputation. With diabetes, anytime we have neuropathy, we're obviously at increased risk because of, whether they have, that significant numbness and developed an ulceration, what their vascular status is, do they have microvascular disease? Do they have, significant occlusion or blockages? And then, obviously if they have some form of trauma, which, in our case for amputation, we don't see as much of, but it does happen. And certainly sometimes we do need to perform amputations due to that trauma. All right. So, kind of getting the back end out of it, we've already established that a patient doesn't have good vascular status, and or we have noted some form of infection or osteomyelitis in the bone, and decided that we are going to kind of proceed with an amputation. There's a lot of things that need to occur pending whether that is some form of acute infection that is going to be an immediate amputation or something that can be planned and or staged if we need it to be. Certain things that we have to consider when thinking about amputation planning, and I kind of listed here certainly are, we have to have that discussion with the patient as well as their family, because a lot of times their family is hopefully involved in that decision making. I think a lot of times when these patients get to the point where they have needed or need an amputation, it can sometimes be a wake-up call for them, or sometimes it can be a very difficult decision because you are, losing a part of your body that, has been with you your whole life. So it can be very daunting for patients as well as their family. And, we obviously try everything we can to try to prevent that, which is the purpose of, this whole group. But um, sometimes it's just better for the patient, or it's a necessity because of that significant infection and or vascular disease. The psychology of amputations, obviously, again, that discussion that you're going to have with the patient and their functional status. So, how much is it going to affect their daily life? How much is it going to affect their gait, how they walk, how they get around? Obviously, that's going to depend a lot on at what level that you're performing the amputation. But it is certainly a discussion that needs to be had with the patient and their family. Next, the level of amputation. I kind of show several of it here on the right hand side as far as the foot amputations, and I focused mainly on those for this discussion. Obviously we have our major amputations in a below knee or above knee amputation, but the picture here kind of depicts those different levels of amputation, whether that's at the digital level, as we're moving back into the metatarsals, um, at the midfoot or the Lisfranc joint, and then the higher up as we go into the Chopard's and Symes amputations, um, and then post-operatively, uh, again, you're going to have that discussion with patients, how they're going to take care of this post-operatively, how they're going to hopefully get these incisions to heal. As we move more proximal, sometimes those incisions get more difficult to heal, and you have to kind of talk about that with the patient, and weight bearing status and all of that, as well as once they have the amputation performed, long term, how are you going to prevent any more amputation from occurring? So, or we don't want to lose more of their toe or more of their foot, or even their leg, and so how are we going to prevent that? So, a little bit about the psychology of amputations. Obviously, traumatic amputations are a lot more, cause a lot more post-traumatic stress, and as you can see here, PTSD after a traumatic or an accidental injury and amputation is somewhere in the range of 20 to 22%. Now, more in our realm, which is the non-traumatic amputations, infections, things like that, it still does occur, but it's more closely to like around 5%. But it's still something that can occur, and I think it's a good discussion to have with patient as far as expectations, what they can expect, and it's something that they're going to see every single day. We see it week by week or month by month, and it's pretty routine for us. But for someone that had a toe yesterday or had part of their foot yesterday and wakes up the next day and is missing part of it, it can be very traumatic for them. So I think, as much education and discussion that you can have with them and their family, the better they're going to do in the long run. And depression does play into that. Like I said, if you're missing part of your foot, and these patients already have some degree, especially if they've been dealing with an ulceration for a month, 6 months, a year, that's something that can be daunting on their mental anyways. And then to end with not the wanted result, which would be ultimately healing, instead ending with an amputation, that can certainly end in some depressive state. So, having that conversation, or even, sometimes setting them up with some form of education, or, a discussion can be beneficial for the patient, and I think end up much better in the long term. So, again, patient preparation, discussion with the family members, discussion with the patient, about what to expect, how they're going to end up long term, and what our goals are, I think is a good discussion and thing to talk to them about prior to. Like I said, obviously this depends on the situation of the amputation and how it got there, but regardless, it's a good discussion to have. So next, we'll start talking about the actual levels of the amputation. So certainly this depends on a lot of factors, and we'll kind of get into that, but we try to keep that as far distal as possible. If we can prevent a below knee amputation by performing a more distal amputation, such as a Symes or transmetatarsal amputation. We tried to do that for functional capacity. And so we'll kind of go through each level here and discuss it. Now, there are certain factors that depend on that. Obviously, if you have osteomyelitis in the heel, you're not going to be able to perform a digital amputation and get rid of that. So it depends on where that infection is, as well as how much good blood flow they have to those areas, if they're going to heal it or not. So the vascular status is very important, and working kind of in a multidisciplinary approach closely with the vascular status as well as infectious disease, and getting everybody involved to try to get the patient the best outcome possible. So functional capacity also plays a role in that too. A patient that is going to be a lot more functional afterwards, depending on what that amputation level is going to be better in the long term, as well as the biomechanics of the foot. So once you start getting a little bit more proximal in those amputations, you worry about the biomechanics of the foot. Are we detaching this certain, tendinous attachment? Is it going to affect the foot? How's it going to distribute the weight? And can it create some further issues down the road? And then, like we talked about previously, patient acceptance. So, really getting the patient on board and accepting that, this is what is going to occur or what has to occur. And I think, a lot of times it is that wake up call that I've had patients that they've gotten to the point where they needed to have an amputation. And I think a lot of times it helps them, try to pay more attention to their body or their diabetes and control their blood sugars, or their smoking, obviously affecting their vascular supply. Sometimes if they do lose part of their foot or a toe, it kind of wakes them up and says, maybe I need to pay attention to this, or maybe I need to address this so that we don't lose any more of the foot or lose any more of our leg. So, like I discussed, the level of the amputation is often dictated by the extent of the disease. So where is that infection? At what level is it occurring? And are we able to, eradicate that infection by the level of the amputation that we performed? The healing potential of the stump has a lot to do with the vascular status. A lot of times, especially in these bad diabetics with peripheral vascular disease, they may have gangrenous changes just at their toes, but that doesn't mean that they're going to heal just a digital amputation. And that's where you're going to kind of have to work closely with the vascular surgeon and make sure that we have enough healing potential there to get that healed, or do we need to come more proximal so that we can get healing and perform that in a single amputation, as opposed to kind of staging it there. And then again, the rehab of the patient, how functional are they going to be post-operatively, and are we going to be able to control pressures post-operatively? So digital amputations first. Obviously, this can be at a couple different levels here. We have the interphalangeal joints in the toes, which, as you can see in the picture here, this gentleman had a distal ulceration, which had been present for several months, I think up to a year. And when he presented to our office, he had significant swelling and drainage. And when we got an x-ray, we were able to see that he did have some osteomyelitis in the toe. At that level, a lot of times we can just perform a partial digit amputation at the interphalangeal joint and get them healed, and they can do pretty well. Obviously, prior to this, if he did not have an infection in there, we would try something else, like a flexor tenotomy or offloading, to try to get him healed. But once they have developed the osteomyelitis in that distal phalanx, as well as the patient was kind of agreeable to it because he had been dealing with it for so long, removing the distal part of the toe, he still has the toe, keeping everything else in a line, and was able to go on and heal and do it well. At the digital level, as far as post-operatively and really tendon balances and things like that, you're not really going to have to worry too much about that. The goal here is to get the ulceration healed or get the infection under control, remove the ulceration, and get the patient kind of back to their functioning status. So here, I don't know if you can see, this is kind of just a picture of how quickly that, osteomyelitis can kind of get into that bone and kind of erode a lot of that distal phalanx there. So the picture on the left, at the second toe, this gentleman had already had a partial ray amputation in the first and began to get some increased pressure to that second digit, had a distal tip ulceration similar to the previous picture. And these two are about 6 weeks apart. And when we get the second x-ray and see that most of that distal phalanx is kind of eroded away, at that point that he does have infection into that bone, and you try to remove that infected portion, get rid of the ulceration, and try to get him healed. Now, obviously, the concern when we start performing these partial amputations is, will it move to that next toe? A lot of times they do have that kind of hammer toe or the curling contracture there. So if we can perform, tenotomies on those other toes to really alleviate the pressures there and prevent this from moving downstream, that's going to be ideal. And a lot of times it will. Sometimes it doesn't. We continue to move and do have to perform further amputations, but obviously the goal is to not have to. All right. So next is the ray or partial ray amputations. So as we move back into the metatarsals here, a lot of times we're performing these more so either on the first or fifth partial ray, but it does occur sometimes if we have those middle metatarsal pressures where they've just gotten, offloading's not worked, or they've let it go so far that they do have some osteomyelitis within those metatarsal heads. A lot of times when we're doing or performing these functions, sometimes the x-rays can be deceiving or not definitive there, whether or not we need to perform a partial ray amputation. So a lot of times I'm getting an MRI to see what the extent of is the infection within that metatarsal, at what level it is prior to performing the amputation. When we do perform these partial ray amputations, a lot of times we are making a second cut as well to make sure that we have a clean margin, because the last thing you want to do is perform a partial ray amputation, leave some osteo in there, and then they end up not healing, or you have to go back in and kind of clean that up. So the MRI is going to give you a better idea of how far back you need to go, and then if you're able to perform that second cut, send it and see if there is any residual infection in there. That can be helpful. And also with these two, getting infectious disease on board, depending, and we'll talk about that too, as far as how long you need to keep these people on antibiotics, whether, you do see clean margins or if there's still some residual in there. So this is a partial fifth ray amputation. This gentleman came in with a bad diabetic ulceration to the lateral fifth metatarsal head there. At his initial presentation, did not see anything on the x-ray, but he didn't progress over a couple of weeks. So we did end up getting an MRI on him, which did show osteomyelitis to that lateral fifth metatarsal head. Now, obviously, you could approach this a couple ways. There was no osteo within his digit or the proximal phalanx there, so you could certainly just go in and remove that fifth metatarsal head and see if he would go on to heal to take the pressure off there. I find a lot of times that they just don't function well. Sometimes you can get the toe flopping a little bit there, and it just doesn't. They end up getting a sore on the toe. So I think a lot of times just taking that whole partial ray there, patients will heal it up a lot quicker, and functionally they'll do a lot better. When we get into the more ray amputation on the fifth, then you do start to get concerned with that peroneal tendon attachment at the base of the fifth metatarsal. Obviously, we try to salvage as much of the attachments as possible, and keep that when we do perform those ray amputations, keeping it as distal as we can while eradicating the infection and allowing them to heal. So once we get past the ray amputations, then we start talking about transmetatarsal amputations. Transmetatarsal amputations are a lot of times kind of the workhorse of amputations once you start moving a little bit more proximal there. My rule of thumb is, once we start losing several digits, I find functionally patients do a lot better just performing a transmetatarsal amputation. So, if they're missing their first and second toes and their third toe or sub-third metatarsal gets an ulceration, I think rather than just removing the third toe, moving towards a transmetatarsal amputation functionally is a lot better for patients, because a lot of times they do have continued sore and will end up with more amputations, more surgeries in the future. And if you can get them healed with the transmetatarsal amputation, I think they'll do well with a toe filler in their shoe and not hopefully break down any further. Okay, so we'll go back a little bit. All right. So when we get into these, so this gentleman here was already missing his fifth digit as well as a partial first ray amputation, developed an ulceration sub-fourth metatarsal head there. Did get an x-ray which showed osteo and confirmed that with an MRI. Because of the location of the ulceration, as well as he was already missing several of those digits, it was decided at that time that a transmetatarsal amputation was his best bet at kind of getting healed the quickest and functionally kind of getting back on his feet. He'd been dealing with this for quite some time. And so we had that discussion and he was agreeable to it. So these are his x-rays here. So on the left was his initial x-ray, where you can see he had the partial fifth ray amputation already, and began to develop that osteomyelitis in the fourth metatarsal. So rather than just, removing partial of that fourth ray and leaving him with the two digits and then probably would have broke down sub 2 or 3, we decided to go ahead and do the transmetatarsal amputation. In his case, when we did the transmetatarsal amputation, he's pretty non-compliant, and sometimes these TMA sites can be difficult to heal. He ended up with further infection within that fourth metatarsal. Despite, a clean margin initially, he did end up with some continued pressure to that area. And we did end up having to go back and resect further. However, again, like we discussed, when performing these, trying to maintain those attachments is, most important to maintain his function as well. And he also did have a Achilles lengthening in between the second and third as well to really help kind of heal those. So when performing the TMAs, performing a lengthening on the Achilles tendon is almost always beneficial. A lot of times these patients have increased pressures to their forefoot, which is why they develop the wounds to begin with. And so if we can perform a Achilles lengthening, I think it's beneficial to alleviate some of those pressures on the forefoot and really allow them to heal quicker and more long lasting. So as you can see, when patients don't have that lengthening performed, they have almost a 20% increase in pressures to the forefoot, which can lead to incision breakdown, wound breakdown, all that kind of stuff. And it can end up with further surgeries or infections. And so by performing the lengthening, a lot of times the patients do very well with it. Usually we'll perform what's called a TAL, which is, 3 incisions that are performed often percutaneous to the back of the leg at the Achilles tendon insertion, and they do pretty well. So that's for the TMA. Next, as we move proximal into the Lisfranc joint, this is really where we're going to start worrying about kind of the biomechanics of the foot and the increased pressures, because we are going to start losing tendon attachments and that kind of stuff. So as you can see here, the ones that I kind of hit on were the Lisfranc, Chopart, and Symes. So this is a gentleman that came in, pretty significant vascular disease, as well as, didn't have any ulcerations at this point, but his was in critical ischemia here. So he went right to vascular surgery. They opened him up. We had kind of a short window to try to save as much of his foot, because basically it was, a below knee amputation, or we could try to salvage some of the extremity here, and patient opted for, to try to save as much as he could. So once he got revest and we went in to perform the amputation, the picture on the left is kind of right at that Lisfranc joint. I think it's a good depiction that, yes, that tissue looks fairly healthy. However, he's still going to be left with an open wound, and with his vascular status as bad as it was, I don't think he would have gone on to heal that. You could certainly have tried a wound vac there to try to get that to fill over, but with the length of time, I just don't think he would have done well. So we made the decision to, go back a little bit farther to the Chopart joint and resect these bones, and we were able to get him closed here on the right. I don't have another picture, but he did end up going to heal, was able to get into some bracing and a shoe, and has done pretty well. So those are kind of the level. I didn't really hit on the Symes amputation quite as much. I don't perform a lot of it. I find that I think patients functionally do better once they get to that point. If they do, a below knee amputation, I think if they can get into a prosthetic, they can function a lot better and get back to their life a lot quicker. So next, post-operative care. So how do we take care of these amputation sites post-operatively? In the immediate post-care, we're worried about that incision. Is the infection under control? And, do they have enough vascular supply to heal that wound? A lot of this stuff, the vascular supply, obviously we want to try to take care of prior to the amputation. So if somebody has, poor vascular status and they come with an infection, have that discussion with the vascular surgeon, or, at what level do you think they can heal this amputation? And that's going to depend a lot on, where you're going to amputate. Wound care, a lot of times if we can get it closed, I try to get it closed. Obviously sometimes we do have to leave it open and have a wound vac or something like that for that last little bit of closure, which is okay. But, a lot of times these patients are non-compliant, and if we can avoid having to use a wound vac, we will. I will sometimes do an incisional wound vac, particularly on my TMAs. I find that they do well with the TMA incision, and they do help with that healing, leaving it on for a week or two, especially, with those TMAs, sometimes they do dehiss, and I found that the incisional wound vacs do pretty well for that. The infection control, again, this is where you're going to, once you get to that ray and partial ray amputations, getting those clean margins is going to ultimately determine how much infection control you need to do as far as antibiotic therapy, and working with infectious disease is going to be beneficial there. So the infection control, a lot of times if it's osteomyelitis and I'm removing a digit, or even sometimes into a partial ray, as long as I have those clean margins, I will leave a patient for about 7 to 10 days on an antibiotic orally, just to make sure that they're going to heal that incision and we don't have any residual infection in there. Obviously, if the margin does not come back clean and you already have performed closure or something along those lines, then that's something that you want to work with infectious disease a little bit closer to control or decide whether or not they need to be on suppressive therapy there or like an IV antibiotic. Um, so that's it for the presentation portion. I was going to do a little case study here and just kind of show how working with the vascular disease and trying to limit as much amputation as we can and getting to healing it can be beneficial. So this is a 73-year-old gentleman, significant history of diabetes, CAD, congestive heart failure. He did have peripheral vascular disease, and he had a history of an ulcer actually on the right foot that we did end up getting healing, and that's what he was presenting initially to the office for was his right foot, and then just kind of happened to mention, oh yeah, my left foot's been hurting. We take off the shoe and see this. So, foot's cool to the touch. He's starting to get some gangrenous changes there at the toes. So when he presents to the office, it's an immediate call to vascular surgery. They were able to get him in fairly quickly and do a revascularization. He came and saw me, I think this is 2 weeks later on the left here. After the surgery, we're kind of letting that demarcate, see, what's going to make it, what's not. Um, Obviously at this point you have concern for almost all the digits. Is he going to develop infection in there? At this point, everything was kind of stable. And then the next picture, again, 2 weeks later, that fourth toe was really not starting to look good. And he was starting to develop some changes from the dry to wet, getting a little more bacterial growth in there. So at that point, I had the discussion with him and his wife. Obviously he he owned a business, was on his feet a lot, was trying to, not lose any of his toes or foot or anything like that. And we had a, pretty lengthy discussion about, if we do nothing, I don't think that toe is going to make it. And, it could get infected and you end up losing more of your foot. So I think it was a good example of having the discussion with him, acting a little bit earlier before it got to that point. Maybe losing one of those toes isn't the worst thing in the world if it saves the rest of your foot and, you're able to get back up on your feet and do what you want to do. And so we decided to perform a fourth digit amputation, discuss with the vascular surgeon if they thought that he would heal that. And from their standpoint, they did. So we performed the fourth digit amputation and he ended up doing really well and ended up going to completely heal that. Foot looks great. We were able to get him into some diabetic shoes after that because he, hadn't had any of that previously, and did very well. Questions. This is a gift to the patient that after I did have to amputate her toe, she brought me this for Christmas. So
thank you so much. That's amazing. Good sense of humor. So I'm sure that helps.
yes. Yeah.
That's good. Thank you so very much. That was excellent. Does anybody have any comments or questions?
So for the group, I think I get this a lot in clinic, and I'm going to bet that primary care providers hear this a lot. There's a couple things. One is they say everything was fine. I had this tiny thing on my tip of my toe. And then he started cutting and cutting and cutting. And, now I'm going to lose my foot or something. Or they come in with a bad wound that needs to be drained. And even when we explain it to them, they still don't understand that, like, we're going to pop this toe off to drain it, but you're not done. We still have to do what we call a definitive procedure where we're going to complete it. And I was wondering in our primary care providers, if you hear that from patients and what your response is.
I personally haven't heard that from any patients, but I've not seen any patients pre-amputation and post-amputation. So
anybody else get that kind of feedback, or they're kind of, the patients are confused? You know, I thought I just was going to go for my toe and now I have below knee amputation.
Sam, I get that. I actually just had a patient today that I've been seeing with a plantar sub-second met ulcer. It calluses over, and he said every time I come, you cut it open and you make it bigger, and you try to explain to them, yeah, if we let it heal over, then the necrotic tissues underneath, it's going to become worse. It could, tunnel, and it's a difficult topic. I could imagine for a primary care it'd be even more difficult to try to explain it. But I get them to come from other podiatrists or even vascular, wound care, and they say the same things, but it's just trying to re-educate them. And then I don't really have a good answer as far as what to tell them. But I just try to explain it and go from there.
I think the purpose of this talk particularly is to help the primary care colleagues understand, like, I think it was something that I didn't understand until I was a surgical resident getting my vascular rotation, that there's not an option after you take half the foot, the next level is below the knee, that there are these staged levels. The reason for that is because you can't be functional. So we have to go to that level, otherwise, because it's either the energy required to walk with it, or you'd be like knocking yourself over because you couldn't make a prosthetic that would work. Like, so if you only take all the way at the ankle, like the Symes amputation, what Dr. Michael was kind of talking about, doesn't really get done unless it's like for an oncology reason in a child. I would say probably the most common reason for that. That's when they like literally just take it at the ankle. And it's just because they don't make good ankle like prostheses that can do the function of an ankle and walk in a natural way. And then again, the concern of like taking too many toes, right? The too many toe syndrome, where someone's lost their first, their third, their fifth toes and refusing that last, or they have like one toe left. That's not a functional foot. That toe is just waiting to get pressure on it and end up with an amputation there. So that's why they say, we can do this, but it's going to change the morphology of your foot. You're not going to be able to walk properly. You're going to just develop a wound on something else. And then, if we're not lucky and we catch it in time, then there's going to be an infection that spreads all the way up, and then you'll lose a leg. If anyone else has experience there they want to share, the time is limited at this point. All right, any other questions? Okay, well, give a big thank you to Dr. Michael. What is next on the curriculum?
Yeah, so thank you again so very much. The next time is May 21st with Josette Bassencos, and it's recipes for managing venous ulcers and other common wounds in primary care settings.
So it'll be a venous talk. So you guys will finally get a little bit more information on that. And I'll just check with Josette, make sure she actually is going to show up, because she hasn't come to any of our echoes yet. So
Yeah,
she moved over to Fairmont. So
the sooner or later we can definitely reach out and make sure that happens.
sure.
All right. Well, I really appreciate everybody. If you have any questions or need anything, please reach out.
Just, can you tell me the date again?
Yeah, of course. The date is May 21st.
What, at noon, obviously.
Yes.